Very nice to see all faces here online with us. And well, you know, before we start, a bit of the house rules, but most of you have been with us in previous webinars, but you know that we have, again, as I said, interpretation. So make sure you're on the right channel, on the interpretation glove icon. And you know that we also have Q&A spaces after each presentation. So we will allow space for questions after each presentation. And then at the end, we always encourage you to share experiences at the end, that we will have an open discussion. And we hope to hear from all of you and your experiences. And with that said, so today we will be discussing exposure treatment therapy as a type of therapy that many of you, as I understood, have experienced or are starting to explore. And to discuss that, we have with us today Linda Nordin. She's a PhD and psychologist at Dignity, and Jorin Blokland. Well, I know your surname is longer, right? But I hope that's Jorin
Yes.
van der Jagt-Blokland.
Yes.
Yes. And Jorin, you are a clinical psychologist, junior researcher, and coordinator of international collaborations at the Psychotraumacenter in South Netherlands. Yes. So we will start with Linda. Linda, you want to go first? Feel free to share screen.
Yes.
And the floor is yours.
Thank you very much. So I'm going to try to get these screens right. All right. So I hope you can all see my screen now.
Yes. Now it's perfect.
Very good. Thank you. And please feel free just to stop me at any time to have a question, comment, a remark, or discussion along the way. So me and Jorin sat down a while ago and discussed what could be interesting to go through, to talk about on such a special event as of today. And we decided to go back all the way from the start, like where did this all begin, this exposure, trying to cope with fear, where did it all start? So we'll go through a bit of history, and then we'll move into the PTSD domain and the current treatments of today and our experiences of it. So I'm gonna try to get rid of some text here. Yes. So what is this exposure therapy? So it's actually, I'm very sorry, but my screen is I can't see. I'm very sorry. Yes, I see my screen. So exposure therapy is a psychological treatment that was first developed to help people to confront their fears. We know that avoidance is a very helpful process that we all use in our lives to come to terms with fearful events. And most of the time it's very functional. If we avoid things, we don't burn ourselves, we don't get into harm. But the problem is that we as human beings are very good at connecting harmless objects to fearful responses. And this is very true for the diagnosis of PTSD. And therefore, confronting, exposing ourselves to fear is a vital part of the therapy programs that we use today in our PTSD programs. And exposure therapy has been scientifically demonstrated to be helpful in treatment for different types of phobias, for panic disorder, for social anxiety disorder, obsessive compulsive disorders, PTSD, and general anxiety disorder. So it's not only for PTSD problems that we use these therapies. You've probably all heard about Pavlov and his dogs. This is where it's all started a very long time ago. Both animals and human beings can develop specific fears when they've learned that something in their environment is dangerous. Pavlov showed that by ringing a bell at the same time as he served food, the dog started to combine the ringing of the bell with the salivation, as seen in this picture. This was done already back in 1871, I think. But the first person who started to give us the exposure therapy was actually a woman called Mary Cover-Jones in 1924. You might have heard of the little Peter that had a phobia about rabbits. He was very scared of white little fluffy animals. And Mary Cover-Jones took the knowledge she had from Pavlov that if you, as a human being, have learned that a specific object is dangerous, you can probably also unlearn that the same object is not dangerous anymore. And she developed a treatment for little Peter. And as with most women in history, Mary Cover-Jones was soon forgotten. And the next person in line, which was Joseph Wolfe. Yeah, there she is. It was Joseph Wolfe that gave us the systematic desensitization. Wolfe was the first person who actually did a manual of exposure therapy. The exposure therapy was done in 3 steps. First step is identifying which objects that the person is fearful of. And then he taught his patient a relaxation or a coping technique that they could use to lower the anxiety or the fear in this situation. And then the final step was to use these techniques as the person put themselves in this fearful situation, learning that it was not harmful to be in this specific situation. We still use some of these techniques in our cognitive behavioral therapies today. And I think Jorin is going to go through this in a little bit more detail when it comes to the programs and therapies that we're using today. Research moved on, and in the 70s, we actually realized that exposure is just as effective without using the relaxation part of the therapy. Yet further along the way, in the 2000s, we also saw that the exposure therapy could be equally effective without coping skills. So we don't need to teach our clients coping skills in order to be able to have benefits from the exposure therapy. And with FOAS work, with PTSD in prolonged exposure, we also know that high arousal from the start, so not building up the exposure therapy gradually with more and more anxiety, is also as effective as doing it stepwise. So what has this got to do with PTSD? Well, you all know you all know the types of symptoms that our PTSD clients come with when they enter our clinics. They have a strong re-experiencing of the trauma situation, with intrusive memories, with flashbacks, nightmares. This leads to avoidance. If we relive the worst moments of our lives, of course, we're going to start to avoid anything that reminds us about what's happened. It also has a big impact on our thinking, our mood, and of course, this changes the way that we feel in the present moment. We know that PTSD patients often have a large number of fear stimuli, so they are fearful of a lot of different objects, a lot of different situations, thoughts, feelings that are related to the specific trauma. The fear responses are excessive. They are not just a little bit scared as you and I can feel every day. They are phobically fearful of these reminders. They come with strong sensory details, images, sounds, pains, smells, which makes them feel like it's happening all over again. This leads to horrendous associations between the stimuli and the danger. So they know that these situations, thoughts, are not dangerous, but they feel like if they are dangerous, and they can't stop this association themselves. This makes them feel very incompetent. So if you lived a normal life before, and then all of a sudden you're scared of all types of different situations, objects, peoples that you normally didn't find fearful before, you're going to start to feel very strange about yourself, very incompetent about what you can handle in life. We also know that the memories of the trauma situation and everything related to the trauma situation is poorly organized in our brains. The memories are fragmented and not stored in the same way as normal memories, which makes life very confusing. We cannot rely on our brains the way that we normally do in everyday life. So, to be able to cope with this situation, we try to avoid. We avoid two types of things. We avoid our inner processes, our cognitions, being memories, being thoughts, being feelings. But we also avoid everything in our external environment. We avoid people, places, conversations, object, situation. This we do in an attempt to feel safe. But what happens? The more we avoid, the more we experience fear. This also limits the activation of the trauma memory. If I do anything I'm capable of, not to think of a certain thing, then my brain will not be trained in thinking of these kind of processes. If I don't think of a specific thing, I will not have corrective information about that situation, place, object, person, or memory. If I don't think about a specific thing, I will not either be able to organize my memories in the way that I normally do. So every time we retrieve a memory, we help organizing that memory once again. This doesn't happen if I use all my energy to avoid thinking of what happened to me. So I can't change my memory either. It will stay disorganized in my brain. So what different types of exposure do we use to come to terms with this inner fear processes? Well, there are 4 kinds of different types of exposure. We have the in vivo exposure, where we go out in the real world and we try to come closer to situations and objects that we are fearful of. That could be spiders, if we relate to a classic phobia. But for our clients, it could also be taking the bus to live a more valued life. One of my clients that I've been exposing, he used to love fishing, going for long fishing hikes. But he experienced war and trauma. And as many people that are tortured, the ones torturing him used his love for fishing in the torture sessions, combining them with fearful stimuli, making him super fearful of water and fish. So I had to take my wellies on and go out and fish with my client to expose him to this stimuli again. The second type of exposure that we also use for PTSD is the imaginal exposure. By asking our clients to vividly experience memories of their past. We can do this by asking our clients to write in details about the feared situation or the memory, or we can ask them to talk about the trauma memories to us. By doing this, we expose them to the cognitions that they are so scared, fearful of. A third type of exposure is the virtual reality exposure. Sometimes it's very difficult to go take your clients out in real life and do the in vivo exposure. For example, if your client is fearful of flying, it might be very expensive to take them on different planes going around the world. So instead we can use different types of virtual reality in our office to expose them to images, sounds, smells that are the same as in the real world. Also in the PTSD domain, we see several studies coming now where people are exposed to virtual reality settings that are similar to the trauma event itself. So this is a growing section of our treatments. And the fourth type is the interoceptive exposure. Interoceptive exposure is used when our client is fearful of physical sensations, such as the heart pounding or sweating, or any other physical sensation that they might have linked to harm and danger. We often use the interceptive exposure for people that have a panic disorder. They are very scared of their physical reactions. Then we take them out, we run in stairs, we spin them in chairs to make them dizzy and do all kinds of creative exposure programs to be able to help them have the same experience as they are fearful of. All right, so there are the 4 types of exposure that you can put together in therapy and use, and of course you can combine them. Another way of differentiating exposure therapy is by doses. So you can have the graded exposure by starting in small steps and going to more and more fearful situation. If your client is fearful of a spider, you might bring in a small, tiny spider and keep it within a long distance from the client. And then you come closer and closer. You might bring bigger and bigger spiders into the room. So you kind of turn the heat up. Right. Another type is the flooding, which is also very effective. For example, if you ask your client to go on a plane, if they are phobic of airplanes, this is a type of flooding. Or if you ask them to talk about the trauma memory in details while closing their eyes, that is also a type of flooding. The last type that we're still using is the systematic desensitization, Wolfe's manual from a long time ago, where we give them relaxation exercises such as meditation or mindfulness exercises combined with exposure. And please feel free to comment, ask anything along the way if you want to. Getting tired here to hear my own voice.
I will also encourage anyone who has questions to jump on mic.
Yeah.
But otherwise, it's very interesting, Linda.
Okay, yeah. Thank you very much, Bertha. So how does exposure works? Well, we can explain why it works in kind of 4 different ways. You've probably all heard about them. So the first one is habituation, where we explain to the client that over time, the anxiety to this fear object or situation, it will decrease. So if you bear with me, if you stay in therapy, your anxiety will decrease over time. Well, another way of explaining how it works is via extinction. So this is where we say that exposure therapy weakens this learned association between the feared object and the bad outcome. So we think that if we think about the trauma again, we will be totally full of anxiety. We will not be able to cope. It will be horrible. If we can weaken this link, then we say that there has been extinction. We can also talk about self-efficacy. So we can talk about the client being able to confront his fears and feeling the anxiety. So It's something internally happening with the client that he or she is able to cope with the anxiety itself. Or we can talk about emotional processing, so that we teach the client to attach more new and more realistic beliefs about these feared objects, so that the client is more comfortable with experiencing the fear. So these are all different ways of looking at exposure and why it works. So I'm going to skip ahead a little bit here because I'm aware that time flies. What I want to give a little bit of warning about is to sell exposure therapy through habituation. So if I say to you, you know, if you go through this therapy with me, your anxiety will subside. It will decrease over time. That is promising the client that if they stay, they will have less anxiety. Am I sure that this is going to happen? No, I'm not, because there is different ways of looking at why exposure therapy is working. And this could eventually backfire on me, because if I tell this to my client, they might use this as a safety behavior to control their anxiety. It's okay to do this because I know that this is a way to avoid my anxiety in the future. That gives the client an implicit message that the anxiety is unsafe and not tolerable. So instead of saying that you please remain in this situation until the anxiety subsides, I would choose to frame it as please remain in this situation until you no longer expect a total catastrophe. And in the relation to anxiety, instead of saying anxiety is supposed to go down over time, I will try to teach my clients that you can actually tolerate more anxiety than you think at the moment. So I would go for these explanations, not to get hijacked by the habituation and making the client use it as a safety behavior. This will help the patient to go through the experience, an experience that it's not as likely as I thought. It is not as awful as I thought. And anxiety and uncertainty are actually safe and tolerable states to me. Yeah. And I've soon used my time, so I just want to have a last message. It is very, very hard for both the client and the therapist to work with exposure therapy. If the client has spent all their energy to avoid a certain memory, that is the worst thing that has ever happened. Of course, there will be a lot of emotions in the room when we ask them to vividly talk about it. This will also provoke feelings in the therapist, of course, and stress. Am I doing some harm to my client? Is this level of stress, is it actually good, or am I doing something that is not helping the client at the moment? We also have a lot of concerns about exposure, and we tend to exclude patients that have depressions or other comorbidities. But research shows that also other types of clients, as bipolar client with psychosis, they benefit from exposure therapy if they have a comorbid PTSD. We also exclude patients with high levels of anxiety because we don't want to put them through more pain. We also exclude patients that are perceived as fragile because we think that they cannot tolerate the therapy. And we also tend to exclude patients reluctant to exposure. Of course, there needs to be a motivation in the patient to go through these types of therapies, but it's also our jobs to work on this motivation for the right types of therapy. Yeah, why I'm saying this is that I'm very aware that it's also stressful for the therapist to sit in this kind of therapies. And we want the best for our clients. But sometimes we need to realize that we need to push quite hard to be able to give our clients the best type of therapies, being exposure therapies for PTSD. And I'm going to stop there, not to use all the time, and see if there are any questions or if Jorin is taking over.
Thank you so much, Linda. I think it was a very, very good presentation and clear explanation. I'm not sure if there are questions. I do have one question.
Yeah.
I see also Alexis and actually in the chat, Ka Hoe from Health Equity Initiatives Malaysia. He was posing, he was sharing, I don't know, Ka, if you want to go on mic so we can hear your voice. Yes. Hello.
Yes, thank you, Berta, and hi everyone. I was just first of all, thanks a lot, Linda, for sharing this information. It is definitely very relevant to what we do every day with the refugee patients.
Thank you.
What we are experiencing there is here is Malaysia is a transit country where refugees, they are not recognized as legal. Their immigration status is not legally recognized, and therefore they often feel threatened and not safe.
Yeah.
So at certain times when we are introducing exposure therapy for patients who are experiencing, could be PTSD and the others, but mainly PTSD, they would prefer to have only skills, and they do not want to go into the exposure therapy.
Yeah.
So I wonder whether this is a common thing, and how do we normally manage this?
Yeah. So I think this is true for many of us treating refugees. A lot of refugees are not safe. They don't know whether they could stay or if they have to go back to an unsafe situation. I actually discussed this with Edna Foa because I think it's, all of the exposure treatment manual says if somebody is not safe, you should not proceed with treatment. But if it's not a current threat, I think that should not be applied. And I think there are circumstances why you should try the exposure therapy. If there is if the client has the ability to process the therapy, if the current fear or the current harm is very vivid, it's very present, then of course there might not be possible energy and resources to process a therapy. So I'm sorry for not giving you a straight answer. I think the client could benefit from exposure therapy anyways, but you have to do an individual assessment. Yeah, Jorin, do you want to add something to that?
I think what we also notice is that a lot of psychoeducation is important. So explaining the client why you are doing what you're doing, because they are confronted with their fears. So it is a very difficult and therapy, which is very rewarding, but it is also you have to use a lot of motivational techniques, especially with refugees group who do not feel safe, to help them continue the treatment and to help them start the treatment already. What we usually also do is, if you have different techniques in your backpack as a therapist that you could use, that we also explain to the client what the different techniques are and that they can choose which one they prefer. And if it doesn't work, then after a couple of sessions, you switch from technique. But yeah, give a lot of explanation is what we usually do.
Thanks. I will definitely try that out.
Thank you, Ka, Linda, and Jorin. Now I see Alexis has his hand up. Alexis, do you want to ask some question? Is that a question? You have to unmute yourself, Alexis.
Hello. Hi, Berta.
Hi, Khalida. We're just giving the word to Alexis. If we can wait now, I think he's unmuted. Hello, Alexis.
I just wanted to check.
Oui, ok.
This mute.
Oui, je suis très content de pouvoir m'accorder la parole. Bon, j'ai suivi très bien l'intervenant et cela m'a amené à poser cette question pour un éclaircissement. Bon, elle a parlé de problèmes de peur au niveau comportemental de personnes. Alors, moi, je me pose la question. Si une femme qui a été violée par un homme en armes et que, bon, à la longue, cette femme a été soignée et puis elle a quitté dans cette histoire-là. Mais en se promenant dans la forêt, peut-être un autre jour, elle se croise avec un type armé, un militaire, quoi. Bon, cette femme, normalement, elle doit avoir la peur. Mais cette peur, comment nous pouvons la qualifier? Est-ce que c'est une peur normale? Est-ce que c'est une peur émotionnelle? Et si entre les deux, vous qualifiez si c'est émotionnel, si c'est normal, la thérapie qu'on peut donner à cette femme pour qu'un autre jour, si elle se croise avec un homme armé, qu'elle ne puisse plus encore avoir la peur, qu'elle puisse prendre un comportement normal. C'était ça ma question.
Merci, Alexis. Linda, I don't know if you understood the question, if you're on the English channel.
No.
You're not on the English channel? No.
No.
Well, I can try to translate. So Alexis was putting in the situation of, you know, if a woman has been raped by an armed individual, that then when she's exposed to Alexis. Yes, I'm just trying to translate. Yeah. So then when this
oui,
person...
je disais, si une femme a été violée par un homme armé, quoi. Bon, et qu'à la longue, cette femme a été soignée, elle a été guérie, elle est rentrée chez soi sans problème. Mais un jour, en se promenant dans la forêt ou aller au champ, des histoires comme ça, et se croise en cours de route avec un homme en arme. Normalement, il doit avoir peur parce qu'il va se souvenir de ce qui s'était passé auparavant. Bon, je voulais savoir, cette peur que cette femme aura, est-ce que c'est une peur normale? Est-ce que c'est une émotion ou quoi? Et quelle est la thérapie qu'on pourrait donner à cette femme pour que cette situation ne lui arrive plus encore un autre jour? C'était ça.
So Linda, I will try to translate. I guess you didn't
no, I'm sorry, I don't know where the English link is.
Yeah, no, it's on there's an icon that says interpretation. But I will translate that for you now.
Thank you.
So then Alexis was saying if now this woman then finds you know out walking a man with a gun, that reaction that she gets, and then Alexis was asking if that's a fear reaction, if that's I think he said something like over anxiety reaction, something like that.
Yeah.
And then, but ultimately he was asking what type of therapy can this person receive?
So if a woman has experienced rape,
yeah,
and
an armed
she,
person, and then she finds a man with a gun on the street,
yeah, so
that kind of reaction.
Yeah, so it's confronting a man with a gun and having a fear provoked in you is perfectly functional. Going through the rape and being super fearful during the event, all functional. What is problematic is if she relives this rape over and over again in her head, and if she starts to avoid any kind of relationship also with good men in the future, or relationship to other people in general. So these are the dysfunctional fear processes that we try to unlearn or help with exposure therapy. And I would say that any of the exposure therapies for PTSD, being prolonged exposure, narrative exposure, written exposure therapy, could be a good therapy for these type of PTSD situations.
Thank you, Linda. Yeah, I think this is one of the cases where exposure therapy could be an option. We have a couple of questions in the chat. I can read them out loud. Unless Mohammed, you want to go on mic and share your comment on the prison environment that you put on the chat. Otherwise, I can read it out for you.
I think also that Jorin has several slides prepared that will answer some of these questions. So I don't know if we're by giving her part of the presentation we'll answer some of these questions, and then we could maybe see if there are any lefts in the end.
Perfect.
Yeah,
let's do that.
Yes.
Yeah. So Jorin, go ahead. The floor is yours, and then we will address. So just for Mohammed and Sana to know that we acknowledge your questions in the chat, we will address them after Jorin's presentation.
Yes. Thank you, Linda, for the good start of this presentation. I will share a little bit more about exposure materials, like if you do the exposure in vivo and what you can use then, also when you work in prison or in other areas that you cannot go outside or do something with someone. So you already heard the introduction on exposure from Linda, and I want to focus also a little bit more on the memory and anxiety network, because this is also something that we use a lot in exposure therapy, which means that if you have a memory, a traumatic memory, that it is linked to other memories in the brain and linked to other stimuli. What Linda already said, that there are other things, for example, sounds or smells that can trigger people and can activate a memory. So what you sometimes see is that, for example, the perpetrator, if there was an act of violence or a rape, that if the perpetrator wore a blue t-shirt, sometimes you see that it becomes a trigger that all men with blue t-shirts become like a perpetrator, or that people get afraid from all men with blue t-shirts. So what you see with triggers or with stimuli is that it is like an oil, a place of oil that will become bigger and bigger, because then sometimes what you see is that all men become perpetrators, and that people do not want to go to the supermarket anymore because there are maybe men that want to harm them, or that people get triggered by the color blue, or by a song that is about the color blue. So what you see is that those triggers and the stimuli that activate a traumatic memory becomes more and more involved in the person's life, and that you see that people usually isolate themselves, do not want to go outside anymore because they either hear a lot of things that trigger the memories or they see a lot of people that trigger. And we can use that in the exposure therapy. So the theory behind the exposure, what Linda already mentioned, is that there is avoidance behavior. And that is teaching the person actually that because of I am avoiding this, because of I'm not going to the supermarket, it is not happening again. So that there is a fear that people have. We call that a harm expectancy, that something will happen when they are not avoiding. But it can also be because I never go back to the place where this accident happened. I didn't become crazy, because if I think back about this image, or if I think back about this memory, I will get crazy. I will cannot control my emotions anymore, or fearful ideas that people have about that. So we want to change this anxiety network. We want to change the memories that people have. So what it needs in order to be able to change it is that we activate the anxiety, because that makes it possible to change it, and that we teach people a different learning experience, so that if they are exposed to their anxiety, that the fearful outcome will not happen. And these are some examples of that. So people usually say before a session starts, like, I will get so afraid that I will panic, that I will run out of the session, that I will feel very bad and end up in the hospital. These kinds of thoughts is what people can have. And you ask then to a person, like, how credible is this belief for you? So how high do you rate on a scale from 0 to 10 that this will actually happen? And usually at the beginning of the session, people rate this very high because they feel that it is actually happening to them. And that is the learning experience that you want to teach people. So by giving the exposure therapy and by confronting them to their fears, you want this belief to change. So you want this belief that they will get crazy or go to the hospital, that is actually not true and will not happen. So the model of learning in exposure therapy, I will tell you later how this actually works and how we use it in the sessions in our center. But the model is that we actually want to practice in as many different contexts as possible. Because if I'm doing it only in my room, then someone will also learn sometimes, like, yes, I didn't get angry or I didn't get so afraid because I was with you in the room. So if it is possible, we use different contexts and we repeat so that people can learn that there is actually nothing happening if they are confronted with their fears. So the goal of the session, and during the session, you measure how high the tension is of someone. The SUD means subjective unit of the stress. We use that from a scale from 0 to 10 to rate someone's tension. So at the beginning of the session, you ask, how high is your tension if you're going to tell me about this experience. And then during the session, you also ask how high the tension is. And you want to keep this tension high during the session, because this is when you can change the memory in the anxiety network. And at the end of the session, what I already said, you check the harm expectancy. So you check, like, now you told me about this experience. Did it actually happen, what you were afraid of? And then you rate this again. So you ask people again to rate this. And you ask them about their learning experience. So what this teaches them. Because what we believe is that people have a huge power of feeling stress, and that the stress will also decrease again. And that is what you want to teach people, that even if they are very fearful, that it will also decrease again, and they can teach that they are have a big power and can do a lot. So when is your session successful? That is when the harm expectancy was challenged. So you increase attention during the session, but when people can learn something, so that after the session they say, like, even that I tell you this, or even that I was confronted with my fears, it did not happen what I was afraid of. That is what you want at the end of the session. So in practice, what does this mean? We usually spend some time on preparation. I already mentioned before the psychoeducation. So to tell people why we are doing this, to tell them that it is a good treatment, that it is evidence-based, that it is very good, has very good results. And what we usually do is that we rate the symptoms before we start with the treatment. So, for example, you can use some trauma questionnaires. Some people, I think I know from the IRCT, use the Harvard questionnaire, or you can use other scales that you rate the PTSD symptoms of someone. And we also do that after the treatment to see if the treatment was actually successful and if the symptoms decreased over time. What we also prepare is an overview of the traumatic experiences, and I will show you an example of that later. But we usually start with someone while we prepare for the treatment with that we know how many traumatic experiences do we have that give symptoms, and where can we start with. And if it is possible, then we use also exposure in vivo materials. And that means if there are certain sounds, for example, or smells that people are, or if people, for example, cannot use knives in the kitchen anymore because knives are a trigger, then those are materials, or we use pictures of that if we cannot go somewhere or take something with us that we can use, and we try to already think about those before we start the treatment. And what this looks like is we usually use this. We call this a trauma line, which is a short document in which we write very in short the event, so the traumatic experience that people have, with the triggers. So for each event, we also write down the triggers or the stimuli that activate the memory. And then we rate how high the frequency is of the reliving. So from a scale from 0 to 10, how often people relive that. And then in the last part, we write the tension after the sessions. So if the tension dropped in the session. So this is what we usually start with. And then in the session, so if we use imaginal exposure, in the session, the first 15 minutes we use for checking the harm expectancy. What are you afraid of? What is the memory that we're going to work with? What are some elements or materials that we can use? And then we have mostly like 60 minutes that we use for the traumatic memory. And at first, people can tell the story from beginning to end. And then after that, we repeat the hotspots. So those are the moments that give the most tension or the most fear. And then we repeat those. We try to repeat it 4 to 6 times. And we also try to add then the materials. I will get back to the materials, what we use and what we do not use. And then the last 15 minutes, so usually those are sessions of 90 minutes, we check the harm expectancy and the learning experience that people had. And what we do in the imaginal exposure sessions is that the main questions that we use is what is happening now? What do you see? What do you smell? So we ask people to close their eyes, to go back to the memory as if it is happening right now, and to tell me what they see and what they smell. And what we do with this is that we activate the memory. So those are the questions that you as a therapist then ask. What do you taste? And to activate this anxiety, I already mentioned, we usually ask people to close their eyes, to speak in the I perspective, so that it is happening to them, and the present tense. So if it is happening right now, I am there and I'm seeing this or this. And we ask for sensory information, and we slow down on the hotspots and ask for more detailed information on those, because usually there is the highest tension in those hotspots. And you can use certain techniques if you see that because you want to keep the tension as high as possible, but also not too high that people cannot learn anymore, or that they are too afraid to learn something. So you have specific things that you can use to increase the anxiety or to diminish the anxiety. So we can also decrease the anxiety again to tell someone, okay, you can open your eyes now and tell me what is happening, so that you want to stay in contact with your client and help them to not be too afraid in your room. Sometimes I'll also ask a client, for example, okay, open your eyes and try to visualize what is happening on my wall. So try to present on the wall what you see is happening, and then tell me what you see. Those things help to also decrease the tension again if it's needed. And for the exposure in vivo, there were a lot of good questions already on that. We want to use materials that activate the same kind of feeling as with the traumatic experience. But what Linda already mentioned, we use materials that are not naturally fear-provoking. So you do not want to diminish a fear that is actually healthy. So we will never bring in a dangerous man with a gun and expose the client to that, because that's logical and very natural to be fearful for that. So what we use is, I have some examples, I think, yes, pictures of accidents that people get very afraid of. We will not bring them in an accident, but if people cannot read the news anymore because they are afraid of reading the word accident, then we use, for example, pictures, or we use sounds of the police car, so also if you work in prisons, you can work with pictures or with certain sounds, and you do not have to go everywhere to do the exposure. But here are some examples. So I want to highlight that we never bring the patient in real danger, but that only the triggers that are keeping them from living a normal life. So for example, if a client who is tortured has a video of him being tortured, or there's video footage of a rape, we never show that as exposure material, but because it is normal that people react fearful to that. So I do want to highlight that. Some more examples that you could use. So for the conclusion, I think I'm also almost over my time. But exposure is a good choice of treatment for PTSD. It is evidence-based, and yes, it is difficult for both the client and the therapist. But what we see as an advantage for exposure therapy is that if you have clients who are very avoidant, who do not dare to go outside anymore, who do not dare to wear scarves around their neck because it reminds them of something, then exposure therapy is a very good treatment method, because with other treatments, for example, EMDR, you do not attack that much the avoidance behavior and people can still avoid. So if that is the main problem in someone's life, we usually choose exposure. Sometimes you can also combine it with other therapies. I didn't go in detail into that, but you also have now a lot of studies that are investigating if combining, for example, in an intensive treatment that you do in the morning an exposure session and then in the afternoon an EMDR session to again decrease the stress levels, if that is actually helpful, and there are good results at this moment for that. So it is safe to do it, but it is also important to spend time on psychoeducation, also to prevent dropouts. And it is important to take care of yourself as a therapist. So those are my closing remarks for this part of the session.
Thank you so much, Jorin. Very good, also complementing Linda's presentation. I think going also much in deeper with some of the other components that we can find. I found it very interesting, this, you know, how to diminish, increase anxiety levels. But I'm gonna give space here to questions.
Yes.
If anyone has questions, feel free to jump on mic. Otherwise, I can also read them from the chat. Remember that we have a question from Muhammad from HDO, Pakistan. I don't know, Muhammad, if you want to go on mic. You want to activate your microphone? Otherwise, I can read it for you. Or Robert Lai Wild. Good to see you.
Robert Lai Wild.
Okay. I'm known at the IRCT for reading the names incorrectly. So
Lay is a weird one, though. It's understandable. Thank you. Yeah, I had a question, and this could go for either of the presenters so far. So I'm sure a lot of us that work with torture survivors are used to working with people with traumatic brain injury. It's very common. You know, and I'm thinking about a couple of clients I have in particular that have, you know, presentations of TBIs, traumatic brain injury, that include like memory loss. You know, I'm thinking about, I've had multiple clients when I try to teach breathing exercises, they have a very difficult time following my cues and coordinating their breaths and actually like counting the breath. Like they can't do the counting and the breathing at the same time. But then at the same time, right, I see a lot of like generalized fear, like fear of using public transportation, fear of heights, fear of, you know, people walking too close to them that just will sometimes create agoraphobia. They won't even leave their homes. So I'm wondering if like is it contraindicated to utilize exposure therapy with the client with TBIs, or if y'all have any pointers that could you know, help us, you know, better provide services and provide exposure therapy when it would normally be an indicated treatment to these clients.
Good question. Thank you for the question. I think, Linda, you need to add something if I'm saying something wrong, but we do not see that as contraindication. I do not know how you are doing that, Linda, but we are also treating that with exposure therapy.
Yeah, I would say the same. As long as there is a possible learning, then I would go for it anyways. And it's also tricky with TBI because there could also be a fragmented memory from the trauma exposure itself. So it's difficult to say what is the fragmented memory or what is due to a TBI. So I would try it, and I would lower the expectations, go slow and steady, but certainly use exposure therapy.
I see one question in the chat. I think, is exposure treatment therapy embedded in narrative exposure therapy? Yes.
Yeah.
So the narrative exposure therapy has exposure in it. Yes.
And also now, Jorin, that you're referring to the chat, there were a couple of questions here. The first one from Muhammad, HDO, Pakistan. He's asking, in prison environment, could it be possible for therapists to go for the options like taking a client to a point for fishing or a bus ride? Would you suggest something more about this second part of the question? Is that, wouldn't it be uncomfortable for a client already undergoing kinds of stresses? So 2 questions in one. I think the first one you actually referred to it, Jorin, saying that you can use questions, right, in prison environments?
Yes, if you have a prison environment or another environment where you cannot go outside with someone, then you can, you have to work then with the situation that you are in. So then you can use videos of a bus write, or pictures of that, specific sounds that are related to that. So I would try then those types of things if it's not possible to actually go and do something.
And I think, well, he also said if it wouldn't be uncomfortable for a client already undergoing kind of stresses, but I guess that's kind of part of this thin balance that you were explaining, right? To meet anxiety but not exceed.
Yes.
Yeah. So I'm going to move on to the next one is from Sana from Restart Lebanon. She's asking, do you think psychologists sometimes avoid to use this kind of therapy? If they have the chance to choose another kind of therapy, if yes, why? It's a simple observation, she adds.
Yes, I see this a lot, I think, because it is quite hard sitting, listening to a rape in detail over and over again, together with a client that is extremely fearful and with high levels of anxiety. We are also human beings, and emotions are contagious. There will also be a certain stress level in our system. So of course it could be hard to cope with, especially if the circumstances at your setting is not providing you with supervision, with colleagues that you can discuss with training, and all of these things that we need to be able to deliver a good service, but also for taking care of ourselves and being able to let go of our clients when we leave work in the afternoon, and the stresses of the clients where it belongs.
Thank you, Linda and Jorin. I don't know if there are any other questions. Mohammed, you're welcome to go on mic to activate your mic. Otherwise, I can read it from the chat. But he's thanking Jorin in the chat, saying it was a helpful presentation for the therapist, and he appreciates it.
There is a throat problem, so I would request you to go ahead with reading my question, please.
Okay, so I should read it, right?
Yeah.
Okay. So the question from Mohammed is, when avoidance behavior is most common among the clients, and sometimes costumes cause to trigger fear. So when in prison environment, the staff is wearing the similar uniform to their perpetrators, would the exposure therapy work, and a therapist could prefer untraditional talk therapy? That's a very good one.
We didn't speak about, no, that's okay. Thank you for the question, Mohammed. Yes, we didn't speak about uniforms yet, but that is a big trigger for a lot of people. So I would say that is actually the best circumstance to do then the exposure therapy on the uniform, because if the client is very scared for, but it depends on whether those particular people harmed him, because you want, so if it is the uniform, just the uniform, so not the people that are scary for him, then I would say you can do the exposure therapy by, for example, looking at the uniform of the people who work there, or to see pictures, start with pictures first of that. So I would say that you could definitely do the exposure therapy then as well. Sometimes what we also see is another example, that people always choose to sit in the corner, so not with their back to the door, for example, so that they always have an overview. That we see that also as part of avoidance behavior, to keep yourself to feel safe, because if you sit with your back to the door, then something can happen. So we usually also challenge someone, like if you're going to have a meal where you are, then try to sit and exercise, practice with sitting with your back towards the door, for example. Or so we always try to challenge people in that.
Thank you, Jorin. Are there any other questions?
Yes, may I say something?
Go ahead, Khalida.
Yeah, first of all, I really thank to the both presenters and experts because in Pakistan, this concept is still very new and it's hardly practiced, the exposure therapy. So for us, it's really a great thing to learn more. And if the presentation is going to be shared, so we may use it to train our psychologist and maybe share it with the psychiatrist team of our experts. So it's really great. And another thing, because in Pakistan, we deal with a large number of refugees who are really still far away from PTSD. They have been experiencing continuous trauma like Afghan refugees, again and again. So this exposure therapy is really great for our expert team of psychiatrists and psychologists to, to practice. Thank you.
Thank you very much. I think it's super if you want to share the material and our experiences with the therapists. It's super. And I would also say that these types of therapies are quite young within the PTSD domain. It's also been hard on our side to implement these therapies sometimes. Now they are very common, but just maybe 10, 15 years ago, they were not so common where we are either. So there has been kind of a revolution, but it's a very current revolution. So it's great if it can spread, I think. Yeah.
And to add, I will add, Khalida,
yes,
that...
Please.
No, I was just going to remind that we always share the recording and the link to our e-learning site on Fabo, and there you can find the recording and the material of the presenters if they give consent. So then, Khalida, you can actually dedicate a session with your team to go through this material and even watch the recording. Yeah.
Yes, and we have the history to invite people from Dignity for training our people in Pakistan. Lovely. And we share the history of learning new things. EMDR is, our teams have learned, but this exposure therapy is really this introduction of this great therapy.
Great, thank you.
Good. And with that, I'm not sure if I skipped any question from the chat, but otherwise, if there are any questions left, I'm also wondering from the ones who are joining us today, is anyone already working with exposure therapy?
Not
or any type, any of the 4 types of the exposure therapy? Not yet, right, Khalida?
We would commit that we would certainly introduce it, and we share it, the experience with IRCT team or Dignity team or the other colleagues.
Good. And Robert, I see in the chat, he says he uses narrative exposure therapy. Yes.
Maybe we can ask the team in Nigeria. Are they using it? Dr. Uju or Honest who are on the call? Maybe not.
And Martin, I think Martin Songasgas, who asked about.
Martin Songasonga.
Songas.
I haven't been used it yet. It is in the planning to start soon.
Good. Martin, can you tell us which center and country are you joining us from?
I am with Heartland Alliance, the Kovler Center, the Marjorie Kovler Center for Torture Survivors, and I'm located in Chicago.
Good. So there's the intention to start working with this at the Kovler Center, but you haven't had experience yet.
I know one of my colleagues has started working with clients using this model of therapy. But for myself, I believe maybe in a couple of months, because I'm trying to target clients who will be willing to start with this model of therapy.
Mm-hmm. I'm wondering if the centers who want to start working with this type of therapy, if you have a plan within the institution, center, organization to have a training on that.
No, we have been trained. We are like a team of clinicians who have been trained with the net therapy. As this therapy, I asked the question if it was embedded in the net. So because it's embedded, that is the model that we use, like net therapy. Our program, the Kovler, has adopted this model of therapy. And as I said, my colleague has already started using it.
Good. And Jorin, I don't know if you can share a bit your experience with, I guess you've been doing the same with Restart Lebanon on imaginary exposure therapy, right? Imaginary or imaginal?
Yes, yeah, you can use both, but imaginal exposure. Yes, we did a training for that to the team in Lebanon. Yes, from Restart. Yeah.
I don't know if Sana is still with us here, but I remember speaking to Sana. Sana is from Restart Lebanon, and she told me that they are starting to work with it, but not yet confident enough to present their experiences so far.
Yes, that's why, yes, excuse me. That's why I asked you to ask Jorin and the Trauma Center, because they have much more experience than Restart Center. And that's why I asked also about avoidance working or talking about exposure therapy, because all our staff like to talk about their experience, for example, in NET, EMDR, and everything. Unless this kind of therapy, nobody dare to talk about it. Maybe nobody dare to use it. They are a lot of avoidance to use this kind of therapy. This is maybe I have to discuss with Jorin and Trauma Center later on. As Linda mentioned, yeah, I agree. Yes. I totally agree with her that people avoidance to also listen to such a kind of very, very hard story like rape and in details. Yes.
Yes.
Good. Well, then it's good that we had this session today. And feel free to reach out to us, or maybe Jorin and Linda. I can also refer to you if we get any more questions after the webinar today.
Certainly. Yeah.
One natural question that comes to me is in terms of providing training, is that something you do from the Psychotraumacenter Dignity? Is this something you do on an ongoing basis or on demand?
Maybe I can start first. We do trainings for the people that we collaborate with. So if there are any questions for that, then yes, you can reach out to me and we can see what we can do. So we do not have a schedule that every now and then we give trainings only if we see that there is a need, or if there is a center that would benefit from the training, then we can see what we can do. So that's usually how we work.
We don't either have like continuous training. We have trainings in some of our projects with our partners. Yeah, that we kind of tailor to the specific needs in a specific clinic. But I know that there are a lot of also digital trainings, digital supervisions, very good digital materials. So there are a lot of materials that you can start with. Yeah, if you don't have the contacts to get yourself a trainer in your clinic. Yeah.
Thank you, Jorin and Linda. So, for example, if, for instance, there would be one of our colleagues today in the call, and they would be interested in training their staff, for example, Halida, could they reach out to you?
We could, of course, always be helpful to find the proper connections. Whether we could do the training, I'm not sure, but it all depends on the clinic and the possibilities. Yeah.
For sure. And then also, Linda, these materials that you're referring to, like online materials, resources, if you can also share them on an email with me, and I will also make them available on the FABO site. Yeah.
Yes. There are also, I mean, if you want to start to learn, the books, the manuals of the therapies are very, it's like almost a cookbook. So if you buy the book, if it's available in your language, then the narrative exposure therapy manual or the prolonged exposure therapy manual, pick a book up, also buy the training materials for the client, start to read it. That is a good beginning. I'm not saying that it's enough for providing therapy, but you will get a lot of understanding from reading the manuals.
Lisa, go ahead.
Yeah.
So thank you. And as the time draws to a close, maybe in closing to say, we thank very much the speakers. So of the IRCT membership, we are always trying to provide the space for members who have best practice to share with others, both to inspire, to teach, and to also hear some feedback from others who might not be as privileged to have the opportunity to have this kind of training in their centers. What we're trying to do here is to, as we say, inspire, but also to share the knowledge, which I think has happened today. And so for those centers, the 165 members of IRCT all around the globe, if there's enough momentum and centers that are really saying, hey, we think this would apply in the context in which we're working, we will try and pick up that feedback and respond to that, to try to be helpful, to try and see, are there options for, presenting some kind of training or in any event starting, as Linda said, by going on and reading. Some of you might have the privilege of being partners with some of these two great organizations on screen. Others may not have that opportunity. So we'll try and dig deep to see what options would there be if you really wanted to work more with this. As a global movement, that's what we're about. So it's sharing and providing this space for you to be inspired and to learn. And then the next step would be, okay, so what can we do to address this? If it's really something you want to do with your team in your center, it would be relevant for the context. So we can find out together, what more could we do? And we've seen in the past a great example from Jorin's team and in the Netherlands, matching a need that was felt by the center in Lebanon. I'm sure there have been other situations where Dignity has been able to respond to a call from a center for a need for, this kind of support. So It's the exposure for you all to this exposure therapy. Obviously, it seems to be working. It seems to be very relevant, but it's tough. It costs, and it also takes, you know, the time and effort by those being trained to understand well enough to be confident with it and then to use it. So I just want in closing say thanks very much for all of you for joining. And we hope in this global movement that we will continue to encourage you to exchange good practice like this that we hear today, and that members of IRCT will continue to step up for each other, to share your skills with each other, because the feeling of solidarity, knowing, you know, you're not alone in doing this work, I think is an enormously beneficial part of this membership we have in this global movement. But thanks very much, Jorin and Linda, for contributing your valuable time, sharing your knowledge with others. And hopefully we will be able to continue this series. There's quite a lot of traction on these webinars, and they don't stand alone. There'll be a recording of this, and there'll be a follow-up thought piece that comes out of it where we extract all these like nice pieces of knowledge. And then Bert, I think there's also a final evaluation that will come on screen, no?
Exactly. With those closing remarks, we can, I think, put on the poll. You know, it's the post survey with 3 questions that we ask. It's very easy to answer. You just have to click, and that will help us to receive your feedback and to continue improving these spaces. And as Lisa mentioned, we will be sharing the recording, the material. I will also be pasting the link here. I'm not sure, Andrea, if you could pull out the poll, otherwise I can do it. I can launch it.
The poll
now
was
it
just
should...
on our screens.
Ah,
yes.
Okay.
It was fine.
Sorry, because I'm co-host, so I didn't see it. Perfect. So I'm gonna also paste that link in the chat where you can find this, our e-learning site on Fabo. Most of you know about it. And as Lisa was also mentioning, there is also this Insight series that our colleague Hugh from communication, he's also working on. After every webinar, he tries to condense the most highlighted content and turns it into magnific simplified versions of these webinars. I'm also going to share the link here actually to the YouTube channel where you can find this Insight series. How are we going with the poll, Andrea?
We're good.
Good. Okay. So I think with that, we can close it here. Thank you everyone for joining. And the next session, we will be hosting the next webinar on the 11th of October. And that will be a morning session at Central European Time, 9 a.m. Central European Time. And it will be on one of these sessions on children and torture, this series that we're having. This one will be dedicated on discussing from symptoms to treatment, how children as primary and secondary victims of torture, how we can work with them in our centers. So with that said, yes, we can close it here. Thank you so much again. Thank you to Jorin and Linda. Special thank you. And also to the interpreters.
Thank you all.
Thank you.
Thanks
Thank
all.
you.
Take care, everyone. Keep
Bye,
up the good
everyone.
work and keep safe.
Bye.
Bye, everyone.
Bye.
Thank
Bye,
you.
Khalida.
Bye.